Hello, everybody in podcast land. I'm Dr. Ted Thachenkary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Ajay Sahajpal, who is the Advocate-Aurora System Medical Director of the Abdominal Transplant Program and is also a board member of the Milwaukee Academy of Sciences. Welcome to MD Roundtable, Dr. Sahajpal.
Hi, Ted. Thank you. It's great to be here. I appreciate it.
Fantastic. Thanks for joining. First off, Ajay, why don't you tell us a little bit about yourself? For example, where did you grow up? What inspired you to get into medicine, etc.?
Sure. So it's probably not a very exciting story, but I'm a child of Indian immigrants. So my dad emigrated to a small town on the east coast of Canada in 1966. And I was born and raised in Charlottetown, Prince Edward Island, which is a very small place. And most people only know of it through Anne of Green Gables. And that's where I grew up. And my dad was an English teacher. And, where my dad moved, his brother and his sister also moved, two of his siblings. He had a larger family. But I was the youngest, essentially, of six boys. I have one
That's
brother.
That's like a basketball team there, huh?
Basically. And they, to their credit, the kids all went, my parents' generation were all teachers. But the kids' generation were all physicians. So by the time it came to me, it was just assumed I was going to go into healthcare or there was going to be something wrong with me. So I didn't really have a whole lot of choice at that time.
Sure. Yeah.
But
that sounds pretty typical, right, of the Asian American or Canadian interest in healthcare.
Exactly. So, and then, being in small town Canada, we didn't, have the financial means. We didn't travel a whole lot. We had some family in Toronto, but basically we lived and grew up there. So I did my undergrad there. And then I finally left when I turned 17 and went off for medical school, or 18, sorry.
I see. Where did you go to med school?
So then I went to Ontario, the big province in Canada, and I actually went to London, Ontario, which is about an hour and a half outside of Toronto. It's a smaller city, but it's a nice it's a nice sized city. I was a little too intimidated to go right from Charlottetown, Prince Edward Island, with a population of about 50,000 to Toronto. So I took baby steps and I went to London, Ontario as my first, adventure away from home. And so that's where I did my med school. And then I did my residency in Toronto.
I gotcha. Okay. So you were in a fairly big town, compared to where you grew up.
Yeah. Yep. Yeah. London's about 400,000 people. And so it's quite a big town, but it was a good transition for me. Coming from a very small place, it was a nice transition to get a little bit more worldly. Yeah.
Great, Ajay. Going through your training, what would you say were some of your biggest challenges that you had to overcome?
So I think on my end, and I want to say this in a very humble way, I've been very fortunate and blessed. I had good parents that were very supportive and loving, and the path had been laid out through my sibling and my brother and my cousins. So honestly, the school piece came pretty easy to me. Going through and getting into medical school and doing those things was pretty straightforward. I would say the challenges were really self-imposed in that I realized very early on when I got to med school, I wanted to do surgery and I wanted to be really good at it. And then I actually got a pager when I was a first year med student, so I could be called on organ procurements and I could come in and I would skip med school to go scrub in the OR. And so I think my biggest challenge was myself in terms of, satisfying myself. And probably I put too much pressure on myself, if that makes sense. So I felt like if I was missing a case, I was missing out the opportunity to learn.
I understand. I gotcha. So how did you get involved in transplant medicine, Ajay?
Yeah, so life kind of leads you down different paths. So that was never my intent. So when I left small town Canada, my thought was just to be a family doctor that did emergency medicine and move back to small town Canada. And then when I got to med school, very quickly I realized I want to be a surgeon. And then I fell in love with liver surgery. And the way it's set up in Canada, which is the way it is in a lot of places in the world, the transplant surgeons were the surgeons that did the pancreatic surgery, the liver resections, the very cool, at the time, what seemed cool, the big complex daytime operations. And then they would do transplant on the side. So that's the way it's set up in the UK and in Canada. So they do transplant, but really their daytime job is they do nice liver resections and different things. So then I realized I liked transplant, but I liked it because it gives you the technical skills to be able to do anything and operate in any space, whether it's the chest, the abdomen, the pelvis. So if you do liver transplant, you can kind of operate anywhere. And so I wanted to do a transplant fellowship, mainly for the skills, thinking that, in 5 years after doing transplant, I would just switch and just do elective surgical oncology, hepatobiliary type stuff. So that was my plan. And then, as they say, the best laid plans of mice and men, I opportunity came up, and then I went in the completely opposite direction, and I ended up running the transplant program from a very young age. When I was here, I was about 3 years out when they handed me the reins. So
Great. And you've been involved at St. Luke's Aurora as the director of the Abdominal Transplant Program. How long have you been the director there?
So I moved here in July of 2008, and then I officially took over in 2012. I probably unofficially had kind of assumed duties in late 2011.
I see. Great. And for those that might be interested in pursuing a transplant degree, Ajay, how long was your training?
So it's a long time. So I took a slightly unconventional route, but basically I did my residency. So med school 4 years, residency 5 years, and then I did a 2-year fellowship at Mayo Clinic. Most people that want to do transplant or want to go into these specialties tend to do some research or do a master's in their training. So they tend to actually take a little bit longer, even, because they'll do a research year during the residency, and they may do a master's or a PhD during their fellowship. So I actually took probably the shortest possible route to get to where I needed to get to.
I see. Great. Thanks for sharing that, Ajay.
Yeah, no problem. My pleasure.
So tell us a little bit about the abdominal transplant program at St. Luke's.
So we actually have a nice program. We have a very dedicated administration and very dedicated staff, and we have great patients. And so I'm very blessed in all those pieces. So the history of the program here, it really started, St. Luke's has always been known as a heart hospital. And so they started the heart program many years ago in the 80s. And it has always done well, and it's recognized in the state. And then late 90s, the pioneer of the transplant program, Cy Tector, had foresight to see that you needed to start an abdominal program too, because you can offer more hearts by having a heart kidney program and different things. So they made a decision to start the abdominal program. Now, there was another program across town at the medical college at the time that was well established on the abdominal side. But they did not waver. They wanted to start, and they started the program around 1998. It struggled for many years to get the right setup, because abdominal programs are very different than heart programs. And so I think one of the mistakes a lot of people make is they think, well, we can do heart, we can do this. And so it probably struggled for about 10 years. And then I came as the number 2 to a pretty well-known guy who was the number 1 at the time. He had been at Mayo Clinic for many, many years. His name was Jeff Steers. And he was at Mayo for about 20 years. He was a world-renowned transplant surgeon. And they hired him, the medical group hired him to reboot the program here in 2007, 2008. And so I came here to be his number 2 because I saw the opportunity as to be trained and work under him and learn under him, to me, was an opportunity I couldn't give up. So That's how I ended up here.
Got it.
And since then, we've taken the program a long way. So we do livers. We've had some of the best outcomes in the nation at some points. We do kidneys, and we've had phenomenal outcomes over the past several years, and we've been growing it. And we do pancreas transplants, but we have just, and it keeps growing. Transplant is one piece. If you picture a wheel, it's the center part of the wheel, but the diameter, the spokes branch out to the circumference of the big tire. And, we follow so many liver disease patients to provide care to them. The care can now be local. We provide so much care to chronic kidney patients. So we have so many patients we follow through our clinic. Transplant is just one piece of that. But in our clinic last year, we had over 10,000 patient encounters.
Wow.
Yeah.
That's amazing. Now, as far as volume, Ajay, how many liver and kidney transplants do you guys average yearly?
So total, we do about 70 a year between all three organs on the abdominal side. So our practice is set up where we do, and some of that's related to how organs are distributed in the country and how we're a little bit landlocked with the lake and how we have, the medical college across, a couple miles away. So it's just how things get broken up. But basically we do about 25 to 30 livers a year in general. We do about 40 to 50 kidneys a year, and then we do a handful of pancreas transplants a year. And then our daytime we tend to do probably about 100 to 150 sort of complex cancer surgeries a year.
Great. And do you ever get international clients?
We occasionally get international clients. We've had two different pathways. One, we've had some living donors that come from other parts of the country, other parts of the world to donate to a loved one. So we've had the donors come here to donate. And occasionally through the Global and Executive Health Program, we've had some patients that come to receive transplant care at St. Luke's.
I see. It's very interesting. If somebody wants to donate a kidney, how would that be possible?
If someone wants to donate a kidney, it's actually it's a pretty straightforward process, actually. It's come a long way over the years. And so now, basically, all you would need to do is call our transplant clinic, and we have a living donor coordinator who would do some screening questions with the individual. And then if the screening questions go well, they would help facilitate sort of next steps. There's different ways to donate. Some people want to donate altruistically, where they just say, listen, I've always wanted to donate and help somebody. I just want to donate the kidney anonymously and anyone can benefit from it. Some people want to donate to a loved one or a family member or a friend. And so there's different pathways that will play out. But basically, you just have to call and get screened by our coordinator. And they ask basic questions, that would be automatic no's. Like, do you have a cardiovascular history? Do you have, are you on blood pressure medications? How many are you on? Those kind of things. If on the screening tests you come up as too high risk medically, then that would come up during that process. There's a lot of people that are altruistic and want to donate, but then, first and foremost, we have to do no harm. So we have to make sure we uphold the Hippocratic Oath. And so we can't take kidneys from somebody if we're going to make them worse.
Sure, yeah. I'm sure throughout your career, Ajay, you met some incredible people and just very noble people. It's the ultimate gift, right? Yeah.
It is. The living donors, actually, for me, I like to spend a little bit more time with them when I get a chance to talk to them. Because it's the altruistic donors that always pull on my heartstrings, because I just they inspire me in that sometimes these are just people that feel like it's the right thing to do to help their fellow man or woman, and they just want to donate, and they just come forward and donate. Do you know what I mean?
That's amazing. It's very admirable. I'm sure you've got some great stories about that as well, huh?
Yeah. No, there's some great stories around it, and I still remember one from fellowship from residency when I was in Toronto, and there was a guy that donated, and this is the time when living donor liver was still in its early stages. And Toronto is one of the biggest programs now in the world, but they had just started it when I was a resident in 2001. And so probably circa 2003, this guy donated to a neighbor. They weren't friends or anything. And I remember I asked him, I was taking care of him. I was taking care of the donor and the recipient. And basically he just said, my dad was sick when I was growing up, and I would see this guy come home from work, and I could tell he was sick, and he had little kids like with the age I was when I was little, and my dad was sick. And so I thought, if I can try to help him, I'd help him. So the guy basically he didn't know the guy very well. They were just, neighbors, but not close neighbors. But he, just by seeing the kids and seeing the guy being sick, reminded him of his childhood, and he came forward and he donated half his liver, which is a serious operation.
Wow.
And he donated half his liver to this guy, saved his life.
Wow, that's extraordinary.
Yeah.
So Ajay, what was your experience like during the COVID peak? For example, was there a decrease? I would imagine there was a decrease in organ supply, right? Or an increase in organ demand?
So and it has fluctuated. So what I'll tell you is that first, everyone remembers that first 2 weeks when COVID hit and the country shut down.
Yes.
So that first 2 weeks when the country shut down, the transplant community was paralyzed because we didn't know the situation. We didn't have the testing. We didn't know so many unknowns. Could you get COVID from a transplant? What could you do? And a lot of people were looking at the data from Italy and trying to understand what was happening in China with the data around transplant. And probably after about 2 to 3 weeks, because transplant has always been, and I know you're a physician, so you kind of know a lot of this through med school, transplant has always been that quaternary thing that pushes innovation through all different aspects of healthcare. And so very early on, because there's people dying in the waiting list and there was also people dying, the transplant community needed to come up with a plan. And so much work went into with the organ procurement organizations and people to try to figure out who was safe to transplant, who was safe to donate, and testing, that they basically, probably within about 2 weeks of COVID's hitting, they started having rapid tests so they could rapidly test the donors. And then, people would then, if the rapid test was negative and the clinical history didn't add up that they had COVID, then we would use those organs. So probably for 2 weeks, it was basically shut down. And then after that, it picked back up. So that first summer, it was busy. And then we started seeing, as the numbers started to peak again, as you got into the fall, that then the transplant patients were not doing as well if they got COVID. And so we started working through criteria to see, who could get transplanted, who couldn't, how would we take care of them post, those kind of things. But transplant has fared well through COVID after those first initial couple of weeks. But, fortunately, the vaccine came and the medications came, and the health systems were very supportive of giving medication preference in hospital to, the immunosuppressed patients, cancer patients, transplant patients. And so we were well supported, and we persevered.
Yeah, yeah. So someone that died of COVID on a vent in the ICU, did that? So you're saying that did not rule them out to be a donor?
So today, that does not. In the early few months, a lot of people were not using them, but now more and more. So if someone dies of COVID in an ICU related to the vent, there are places that would take the kidney or the liver.
Got it.
Because it's shown from some of the data that that's not transmitted. Now, they wouldn't necessarily take the lungs, obviously, but people have transplanted COVID lungs inadvertently and the patients have done well. But for me, it's a no-brainer now, as long as the patients obviously consent and everyone understands. But if someone comes in and they're asymptomatic with COVID, I have no concerns offering that organ to a patient and consenting them.
Sure, because I remember during the peak, we'd be calling Gift of Hope all the time on our ICU vent patients that were, expected to die, and they would just say no right away.
Yeah, no, and that's what it was like probably. I would say probably for the first 6 months, people were not taking COVID organs. And then what happened is some people started inadvertently doing it where it was a false negative and then the patient did have COVID. Then they were able to see that the recipient actually did okay. And then, that's kind of how it started to grow. And then people were studying it. Just like anything in healthcare, you study it.
Right.
And then you kind of are able to understand the kinetics of how the infection works. And more people are transplanting patients with donors who have COVID in select cases.
Sure. What's the projected survival for a kidney transplant patient?
So it varies by living donor and deceased donor, but typically you when we talk, just like with cancers, we kind of talk 5-10 year survival type things for the graft, different than the patient for the graft survival. A good living donor, you want to have it be 90% or more at 5 years. And then a good cadaveric donor, you want to have it be, 75, 80% at 5 years. That's the ideal. Longer would be better. And there's so many cases of people that get 20 plus years out of their kidney if they take good care of their health and their medications. But we kind of aim for as close to 100 as we can get, but accepting that over time, there's going to be some chronic rejections, infections, different things.
Right.
But for livers, it's kind of similar. So you kind of look ideally 70 to 80% 5 year survival.
Those are great rates.
Yeah. And that's a lot of that come with changes in immunosuppression and work in that field.
Right. Great. Having said that, I know this is sort of a controversial topic, but are there racial disparities in the kidney transplant world? And how can we improve this?
So I think more and more the data is showing that there is, and there's a few different pieces. So what I would say is there's not an intentional racial bias or disparity that's being created. It's an implicit thing that's built into the system that's being worked through. But there were some issues related to listing, and as you probably know, as a physician, the estimated GFR calculators had a difference for African Americans versus Caucasians. And then there was some issues with, you got to take a whole wraparound holistic approach with patients. And most kidney disease, especially in urban areas, are going to be with African American patients. Most of those patients have more challenges to getting on the waiting list or being maintained in the waiting list. And what I mean by that is they're inactive more often on the waiting list, or they take longer from referral from dialysis unit to get listed. And a lot of that is built into things in the process that we don't think about because, when you're in the hospital, you're not thinking about it. But when you take a step back, you kind of see it. So to get on the transplant list, you have a whole bunch of tests. If you're on dialysis Monday, Wednesday, Friday, that kind of leaves you Tuesday, Thursday to get those tests, for example. Mm-hmm. But if you have to take 2 or 3 buses to get to the hospital, and if you're late and your appointments are canceled, so then you get pushed back another couple of weeks. Or if something comes up, something gets canceled. And so there's a lot more steps to providing the care our patients need, especially those patients that are underserved, to getting them on the wait list. So what a lot of places have started doing with renal strategies, and we've been looking at working with, is recognizing that and providing those wraparound services to help shepherd the patients through the process. Because it's not that the center's not willing to transplant them. It's just there's more issues that come up along the way that we take for granted and don't think about, like getting to the appointments or getting to the heart cath, and then, the cycle starts where if you miss one appointment, then you get kicked out another month. And then, so that's why patients tend to be inactive more, or there's more issues with insurance and making sure your insurance is up to date or the medication plan is up to date. So a lot of these things flux that up until recently, people did not take time to put the understanding onto and the emphasis onto. And so ultimately, patients that were African American were being disadvantaged on the waiting list. That's the reality. And they're less likely to have a living donor because the things that drive kidney disease often in African Americans are high blood pressure or diabetes, and usually a family member would have something similar. So it's harder to get a donor. And so they were more often required to be on the cadaveric waiting list. Then there was some unintended biases on the listing based on the estimated GFR, and then there was more challenges to getting on the wait list and being maintained in the wait list. So no question, there's a disparity, and is being looked at and worked through by everybody.
Right. Well, thanks for acknowledging that, and I'm sure your team is aware, and just I guess the first thing is just creating awareness that it exists.
Yeah, no, and that's exactly right. Because if you just focus on the medical piece and you're not thinking about it, you get an organ offer, and then you look at who the recipient is, and if they're active or inactive, you don't usually delve into why are they inactive. You're just making that decision on the organ comes in, it's being accepted, is being offered to this person, you accept it, right? And then, but when you take a step back and you start looking at, well, why didn't it go to this person? Why are they inactive? What are the issues? What are the barriers? So putting resources into understanding those pieces and helping those patients get what they need to get so they can be active and ready is probably the biggest area of focus right now.
Great. Well, I'm going to switch topics here. I think it'd be beneficial for the audience to know what xenotransplantation is and what's been your experience with xenotransplantation.
Yeah, no, that's a great question. So xenotransplant has been around for a long time. It's like the end of the rainbow trying to find the pot of gold, but it's getting closer and closer. So xenotransplant, in the simplest terms, is taking an organ or tissue from a non-human and giving it to a human. So we saw some of this, in the 80s. There was a young girl in Cedars-Sinai. They got a baboon heart, for example, things like that. That is what a xenotransplant is. The thought would be all of a sudden you have an endless supply of organs. This would be great. If we can crack this nut, it would end the waiting list. It would save lives. So many people have been working on this over the years in various capacities. And we're starting to see more and more of that play out, where we're starting to see some progress. And so in the past couple of years, we saw some notable transplants on the East Coast where a patient got a heart from a pig. Now, the difference is in there, they pivoted from taking a pig's heart and giving it to a human. It's actually a humanized pig heart that's being given to a human. So what I mean by that is they're treating the heart. It's basically the antigens being presented on it and different things. It's basically a scaffold with humanized human cells. And it's a lot of nuances in the science, but it's quite innovative. One of my mentors at Mayo has been working on this with pigs at Mayo, and he's got pigs walking around with human livers in them.
Wow.
Because basically you take the liver out, you kill all the liver cells from the pig, but use the scaffold, and then you put human cells back into it. So it's quite innovative. But basically that's where a lot of the work is going. So people have somewhat, pivoted from just trying to create a situation where you're still giving a pig liver that's been treated and trying to suppress antigens and different things to a human, to can you humanize the pig liver or the pig heart and give it to a human? And so that's where a lot more of the focus has been. But I think xenotransplant, based on what we saw the past year with these cases, we're going to see more and more of it. Right. And I think in 5 to 10 years, it may well be a way to get more kidneys for patients, to be honest with you.
Yeah, that was my next question. So pig kidneys, that's also a reality.
Oh yeah, no, that's where the ultimate end of the work is trying to get to, is to the point where you basically can give a humanized kidney, a pig kidney, to a human, so the wait list would then dwindle away.
Are there other animals besides pigs, or just pigs?
So pigs tend to be the ones that actually are the best match for humans in terms of so primates tend to actually have more risk of viral transmissions and issues, and so. If people went away probably about 20 years ago away from baboons and away from chimps and moved to pigs, because pigs actually are, to be honest with you, and you may read into, if you ever read Animal Farm, you may agree. But anyway, pigs tend to have the most similarities to humans when it comes to some of the nuances with the biology.
That's amazing. I'm never going to look at a pig the same way again, Ajay.
Yeah, but the monkeys and primates are too close. And so there's more baggage that comes with that, if that makes sense.
I see. Yes. What are some of the things that excite you the most right now in transplant medicine?
So I would say I would break that up into 3 buckets. One, the science related to xenotransplant. I think that within and of itself is interesting to me, and some of the pump technology. So more and more we're seeing, in parallel to trying to get more organs by creating more organs, there's actually a lot of work being done to preserve more organs so that they can be recovered, treated, made safer, and transplanted. So what I mean by that are there's pumps, there's normothermic perfusion pumps or blood pumps that you can take a fatty liver, put it on the pump for 12 hours, treat the liver to make it better, then put it in a patient, whereas historically that liver would never get transplanted. And so things like that are happening now in the world, and they're just happening slowly but surely, and it's going to become the mainstay in the next few years as well. Same with hearts. So the science is there, and that's pushing the envelope again. And so I love that. That keeps me excited. Innovation in protocols for transplant. So, for example, I recently transplanted somebody with metastatic colon cancer. 10 years ago, that was, when I finished fellowship, that was an absolute no-no. There's certain cancers we transplant, but metastatic colon cancer was not one of them. But now,
wait, you use their organs?
No, we cured them, or we gave them a chance of cure by taking out their liver that was full of cancer and giving them a new liver.
Fascinating.
So, and a lot of this work came out of Norway, but there's protocols now that show that there's certain patients, because every human's different, right? There's certain patients where they have metastatic cancer, but it's all in the liver. And so if they do well with chemotherapy, they do well with treatment, and they're walking around 3, 4, 5 years later, and it's all just in the liver, maybe you just replace the liver. And so someone started doing that, and they showed that there's certain criteria where that actually was successful. And so we looked at the protocol, we looked at the science, and we started doing it. So that stuff is very exciting to me because transplant always pushes the envelope. And so I like that. And then I would say the changes in how organs are allocated and more specifically, the issues around disparities and trying to improve the system to address the disparities gets me excited because I think advocacy and acknowledgement of those things is important. So those are kind of the areas that interest me the most.
That's brilliant. Thanks for sharing that, Ajay.
No problem.
What are some of the interests outside the OR for you? How do you like to decompress?
That one's pretty simple. I spend time with my kids. So I'm blessed to have a 5 and a 7-year-old, and I just spend time with the kids. It's probably I don't really have any hobbies, believe it or not, because healthcare was always my hobby. And so basically when I'm not working, I spend time with the kids, and I love it. That's how I recharge.
Great. Wonderful. In addition to your OR work, I also know that you're involved with the Milwaukee Academy of Science. Can you tell us a little bit about that?
Yeah. And so I guess what I would say is I've always been interested in education. And so when I first moved to town, and education being an equalizer. And so what I mean by that is, my dad emigrated to Canada with $7 in his pocket. I'm able to live the American dream, but I think I'm living the American dream because my dad moved was basically middle class in Canada, where there's a good social system, and I was able to get a good education, get my scholarships, etc. But I was able to get a good education that was affordable. And so I think the playing field is leveled by being able to provide an education. And so I was initially involved with some programs through the YMCA, and then one of my friends was on the board of the Milwaukee Academy of Science. And that's a school that is just north of Sinai Hospital, and it's linked to the medical college as part of its roots of how it was started. But it was started based on the notion that, based on the observation that the old CEO of the medical college in circa 2000, Dr. Bolger noticed that a lot of the kids going into healthcare fields, whether it's medicine or other, were not kids that were local to Milwaukee or African-American kids. It was basically, Caucasian kids. And so he wanted to start a school to put an emphasis on sciences, STEM and STEAM learning. And so that morphed into this school. And I've been on the board for about 8 years, but the intent is really to provide a safe space for our underserved, underprivileged African-American kids to really get a good, stable education and a good, strong foundation in the sciences. And since that time, the school has morphed. So we've expanded. We're about 1,400 kids. It goes from K through 12. We have 96% of the kids actually live at or below the poverty line. Some of them are homeless, but we have a transportation system set up to get the kids to school. We have a summer school program. We have, we have a football team now that we started a couple of years ago. So we want to keep these kids engaged, keep them at the school, keep them. And it's been a journey because those are some of the things, I first got on the board. I'm like, why do we need a football team? The goal is to be an education. And then you start to realize if you're not offering some of these sports, you may have kids that are getting, committing to the education. But when they get 10 or 11, get to grade 10 or 11, they still want a chance to play these sports because they may get a scholarship off it. So if you're not offering a sport, then the kids will move to a lesser academic school because they need to at least have that pathway open as well. Do you know what I mean? And so it's been a learning curve. And then, even getting transportation services is something that, you take for granted, but getting kids bused to school is actually a lot of work. It's not that easy.
That's a huge challenge. Yeah.
Yeah. So it's been a great learning curve, but I've been committed to education on that front. And I've had some good friends in the community that are also like-minded and committed to it. So it's been great. And recently we just received an award through the I Have a Dream Foundation in Milwaukee, where they're going to be taking a cohort of kids from grade 1 all the way through grade 12 and providing those wraparound services for the kids. So making sure they get a lot of the same benefits that someone like my kids would be getting, so that we can see how they do. And then it's being studied to see as a cohort to see if that makes a difference, and then trying to show that education is the equalizer.
That's amazing. That's very inspiring. Yeah. Now, these kids, do they have to pay any fees, or is everything covered?
It's covered. Yep. Yep.
Wow, fantastic. Well, Ajay, I just want to thank you again. You are very inspiring, and you seem like a very humble surgeon. And I just want to, I just want to thank you again for your time. I think the information that you provided will be very beneficial for the audience. And thanks for joining me on MD Roundtable.
Oh yeah, my pleasure, Ted. Thank you for having me. Have a great day.
Thank you, Ajay. Take care.
Thanks. Take care. Bye.
Bye. Folks, if you enjoyed that episode, don't forget to leave a review of the MD Roundtable podcast on Apple iTunes, and please don't forget to subscribe. Stay tuned for our next podcast coming to you soon. Thanks for joining me again, and have a great day.